I'd like to introduce Dr. Anna Adrian, who will be our moderator for today's session. We will be holding another talk next week by Dr. Olga Trivedi on titles Pituitary MRI. Now I'd like to introduce our speaker for today. It's my pleasure to introduce Fraser McConnell. Fraser graduated from the University of Edinburgh in 1993. He worked in mixed practice in Suffolk, UK, where he gained RCVS certificates in veterinary radiology and small animal medicine. After moving to the University of Cambridge in 1998, Fraser obtained his RCVS diploma in veterinary radiology in 2000. From 2001 to 2006, he worked as clinical radiologist at the Animal Health Trust Newmarket, gaining extensive experience in MRI and neuroimaging. He was awarded a diploma from the European College of Veterinary Diagnostic Imaging in 2003 and RCVS specialist status in 2004. From 2006 to date, Fraser has worked at the Small Animal Teaching Hospital of the University of Liverpool as senior lecturer in veterinary diagnostic imaging and head of the imaging service. Fraser has been involved with teleradiology for over 10 years, primarily in MRI and CT. He's trained numerous students and house officers in diagnostic imaging over his 20 years and has served as the chair of the examination committee for the European College from 2010 to 2012. His main interest is MRI and neuroimaging, and he's a co-author of numerous papers, over 60, that includes discal spondylitis, thalamic infarcts, and facial neuropathies. It's my pleasure to introduce Fraser, and I will hand over the talk to him. Just one last comment. At the bottom of your screen is a chats function, so if you'd like to ask questions, you can also raise a hand to pose a question to Anna. I'll turn it over to you, Fraser.
Great, thank you very much, David, for the invitation. Hopefully you can all hear me okay, and greetings from sunny North England. So I'll just share my screen with you, so hopefully you should be able to see my PowerPoint, and just let me know if you have trouble seeing the slides or okay, so let's go. So this is a real interest of mine. So when I was asked to give a presentation, it's a natural topic for me to do, and it's quite an interesting disease to image because of the close correlation between the pathophysiology and also and how that fits in with the imaging findings that we see. So these are the learning objectives for today. So hopefully you'll be able to understand the pathophysiology of the cerebrovascular disease and how that relates to the imaging findings. Hopefully you should be able to recognize the typical appearance of ischemic brain disease, have some understanding to the MRI sequences which we'll be using to image this pathology, and then understand some common differentials for ischemic brain disease. Okay, so cerebrovascular disease really encompasses all pathology of the brain which is related to the underlying vascular supply. So just in terms of terminology, so cerebrovascular disease is the primary vascular disease, and cerebrovascular accident or stroke is the clinical manifestation of that disease. Okay, so cerebrovascular diseases are really common. Pathological studies have shown quite a high prevalence of vascular pathology, so it is something which is quite widespread. In terms of classification of cerebrovascular diseases, they're really divided into two main categories. So we have diseases where we have vessel occlusion, so either thrombus in situ or potentially thrombus originating elsewhere in the body and then embolize into the cerebral vasculature. So this results in reduction in cerebral blood flow, resulting in our ischemic stroke. Okay, so this is the classic peracute onset of neurological signs. So these animals are essentially normal 1 minute, and then the next minute they'll have fairly obvious, in many cases, neurological deficits. The other type of vascular disease we see is when we have a vascular rupture, and this results in leakage of blood products into the brain parenchyma or into the CSF spaces, and this results in hemorrhagic stroke. It's probably best to consider these really as two different disease entities. They present very different clinically. So whereas ischemic stroke is usually peracute and then either non-progressive or will get better over time, hemorrhagic lesions will often be progressive, they'll often get progressively worse. Also, the imaging appearance is very different for hemorrhagic stroke from ischemic stroke, and underlying pathologies which cause stroke are very different for the ischemic diseases and hemorrhagic strokes. Okay, so probably best to consider these really as separately. Today I'm going to be talking entirely about ischemic stroke. The division between ischemic and hemorrhagic stroke is not absolute. When we have reperfusion of infarcts, often we will see some hemorrhage or leakage of blood products. So we may have hemorrhagic strokes which will have some imaging features of hemorrhage, but typically the imaging characteristics are still very much that of an ischemic infarct. So they look very different from an entirely hemorrhagic lesion. Okay. In terms of prevalence of disease, we certainly see a lot more ischemic disease than we do hemorrhagic lesions. So in man, the proportion is roughly 80% ischemic disease, 20% hemorrhagic diseases. It's probably roughly true for our patients as well. Okay, so certainly we do see probably more ischemic disease than we do with non-ischemic. Bit of pathophysiology. So the brain obviously needs a constant supply of oxygen and glucose to maintain its normal cellular function. If we have a reduction in blood flow, such as occurs during thrombosis, then what we'll see is we'll start to have a reduction in neuronal function when cerebral blood flow drops to around about 20 to 40 mils per 100 grams of brain tissue. So at this point, we'll start to see development of cytotoxic edema. We may have neurological signs, but potentially this tissue is still viable. Okay? If the ischemia is more prolonged or more severe, then we'll end up with irreversible infarction. Okay? So an infarct typically will have a gradation of oxygen gradient across so typically the center of the lesion will be the area with the lowest cerebral blood flow, and this is the area which is going to initially infarct. The area surrounding it is ischemic, so there's a reduction in blood flow, but this tissue is viable. Okay, and in human stroke imaging, this is a very important area to try and image, because this penumbra, as it's known, is the tissue which is potentially salvageable if an intervention is done, so thrombectomy or medical treatment. In terms of imaging, we can image the infarct core using diffusion-weighted imaging. So this is an example here of a DWI of a cerebellar infarct. And we can get a handle on the extent of ischemia or reduced perfusion using perfusion-weighted imaging. Okay, so this is a perfusion-weighted imaging, again, of a dog with a cerebellar infarct. And essentially the difference between the size of the lesion on DWI and perfusion really relates to this penumbra. This is, for us, probably academic interest, because obviously most of our patients we see, we're not going to be doing thrombectomy, and usually by the time we see them, it's too late in the disease course to be using medical treatment. So this, penumbra imaging is probably limited clinical validity for us. So in terms of the pathogenesis, really, infarcts classically were divided into two main types. So we have what's called the territorial infarct. So these are typically large infarcts where we'll have a thrombus within one of the large arteries which supplies the brain. And so this will give us our kind of classic kind of wedge-shaped infarct, as we see here. That type that we see are so-called infarcts, are small infarcts, typically the thal, capture, mesencephalon stem. So these occur within the periphery vessels, small end arch supplying the brain parenchyma. In terms of classification, the reason why these are important in human imaging that the roots of the underlying pathophysiology. So territorial infarcts in man are commonly due to thromboembolic disease. So typically there's a high prevalence of carotid artery disease, so atherosclerosis, or also embolism from atrial fibrillation. So these territorial infarcts would essentially be a prompt to investigate these underlying diseases. And also from a treatment point of view, potentially you could do thrombectomy for a large territorial infarct such as this. The lacunar infarcts really relate to often intrinsic small vessel disease. So this is due to pathology actually within the vessels themselves. So hyaline arteropathy, for example. So a slightly different etiology from the thromboembolic disease. We certainly know from histological studies that there is a high prevalence of similar small vessel disease in small animals, and certainly so it it's certainly the same EG in our cases as well.
Fraser?
We typically don't see the same underlying concern. Yes, sorry.
Sorry to interrupt you. Is it possible that you switch off your camera just so your internet connection is getting a little bit better?
Sure, give us a second. I'll just give us 2 seconds. Sorry about that. It's the trouble. I live in a really rural area, and our internet's often a bit flaky, so I apologize for that. So I'll see if we can find stop video. Okay. Okay, right. Okay, let's see what we get on there. Right. Okay. So we typically don't see the same underlying pathologies in small animals, so we don't really see atherosclerosis, and even when we have atrial fibrillation in dogs, we rarely see cerebrovascular disease. So this arbitrary classification between territorial and lacunar infarcts possibly has less validity for our small animal patients. Okay. So how do they live? So one of the key features of the pathology of cerebral disease is that we have concept of vulnerability. What this means is that not all parts of the brain have the same susceptibility to reduction in cerebral blood flow. And the grey matter obviously has a much higher metabolic requirement than white matter. And so with ischemia, classically what we see is that lesions will be primarily within grey matter, or where grey and white matter are involved, we see the pathology involving the grey matter much more severe. Okay? So typically, the classical appearance of an acute arterial ischemic infarct, our lesions are usually sharply marginated, and this is an important imaging characteristic. So we can see this very nicely in this cerebellar infarct here, this very sharp division between the normal and the abnormal parenchyma. They're usually pretty homogeneous unless we have hemorrhagic transformation. Primarily grey matter, or certainly grey matter much more than white matter, and this is important when it comes to differentiating infarct from some of the differentials. Hypertension T2, because essentially we're dealing with cytotoxic edema. Mass effect and swelling is somewhat variable. It's usually relatively mild or modest. We don't typically see much mass effect unless the infarct's very large. Another kind of key imaging feature is that they're confined to the vascular territory of the artery that's supplying that region. And so this lack of crossing vascular territories, again, is an important diagnostic finding which differentiates infarct from other causes of cytotoxic edema. Okay, so the vascular supply to the brain in dogs, in a way, is from two main sources. So we have the vertebral basilar artery, which supplies the cerebellum and brainstem. And then we have internal carotid artery, which is the communicating branch on the circle of Witt. Off the communicating branch, we have the rural middle arteries supply and the sympathy. These are the vascular territories. So this is the figure that's taken from Wilfred Mai's book. And so we can see that the cerebrum is supplied by these three main arteries. So the middle cerebral artery supplies predominantly the lateral aspects of the cerebral cortex. The rostral cerebral artery is rostrally in the midline, and the caudal cerebral artery is caudally in the midline. The thalamus, internal capsule, is supplied by the striate arteries, and further caudally we have the perforating arteries, which supply the caudal thalamus and mesencephalon, and then we have small perforating arteries which are supplying the brainstem. So if we look at the kind of large territorial infarcts, first of all, so in the cerebrum, these are not very common. I see maybe a handful a year of these territorial infarcts in the cerebrum. And when we see them, they're most commonly in the middle cerebral artery. So they're occurring laterally within the cerebral hemispheres. Much less commonly are rostral cerebral artery territorial infarcts. These are pretty rare. Typically what we see of these in terms of clinical signs, these are usually periacute onset, non-progressive signs, forebrain signs. A thing to note though is that seizures are rare. We rarely see seizures secondary to infarction. And again, that history can be helpful when it comes to differentiating infarct from diseases such as postictal edema, which can be a mimic of cerebrovascular disease. So a very nice example here just showing this very sharp margination. This is a very large infarct. This is probably about as large as you're ever going to see. And we can see with this lesion here, there's actually quite a moderate mass effect. This lesion here is slightly heterogeneous because this infarct had undergone a degree of hemorrhagic transformation. More commonly in terms of territorial infarct are the cerebellar infarct, and this is probably the most common territorial infarct you're going to see. These are pretty common diseases, and certainly you would be seeing these fairly regularly. These will present with periacute onset vestibular signs. There is a breed predilection, so certainly Cavalier King Charleses are overrepresented. We also see quite a lot of sighthounds. They are also predisposed to ischemic brain disease. So this is our classic kind of wedge-shaped territorial infarct. Again, we can see the sharp margination confined to one vascular territory. Just a really nice example here. Pretty much they're always, or pretty much always confined to the territory of the rostral cerebellar artery. So this is occurring rostrally within the cerebellum. Caudal cerebellar artery territorial infarcts are rare. Rare diseases. Usually unilateral, but sometimes they can be bilateral, as in this case, and commonly you'll see evidence of them having infarcts elsewhere. Commonly with cerebellar infarcts is often a history of kind of short-lived vestibular episodes prior to the onset of the stroke. So these are likely to represent transient ischemic attacks or kind of mini strokes. In terms of appearance in other sequences, on T1 weighted images, they're usually fairly hypo-intense. On flare in the acute stages, they'll be hyper-intense, and contrast enhancement is somewhat variable, but usually kind of minimal or mild. So this is probably about as much enhancement as you're likely to see with cerebrovascular disease. So this was a large territorial infarct, and we had a bit of meningeal enhancement. This one here is a bit more diffuse enhancement. So enhancement relatively modest. So we're not expecting to see a lot of dense enhancement with our cerebrovascular disease. Aging of infarcts is quite important, or being able to recognize the different ages of ischemic disease, because we do see a lot of chronic infarcts as incidental findings in older animals. And so this imaging clinical correlation obviously very important. So it's quite important that we can differentiate on the imaging whether we think the lesions are acute or chronic. So this is an example here of an acute cerebellar infarct, and the images on the right are 7 weeks later. So typically what we see with chronic infarcts is we see reduction in volume, and they'll often cavitate or undergo necrosis. So they may suppress on flare, or they may be very low signal on the T1. So this is just a really nice example showing this grey matter predilection, so in the selective vulnerability, bit of a mass effect on the acute image, and then in the chronic stages of the infarct, we see this reduction in parenchymal volume. What about cats? Well, this is one situation where cats really behave the same as dogs. So the appearance of the infarcts is the same. We typically see territorial infarcts in cats. It's not common to see lacunar infarcts in cats. Again, history and clinical findings tend to be very similar to dogs. So these are usually kind of periacute onset non-progressive clinical signs. It's In terms of prevalence, we actually see much fewer cerebrovascular disease in cats compared to dogs. And I guess this is somewhat kind of surprising given the prevalence of infarcts and thrombosis elsewhere in cats. So quite why cats seem to be relatively resistant to brain infarction when they seem to be infarcting every other part of the body. I guess the cause for that is unknown. Infarcts may undergo a hemorrhagic transformation. So this usually occurs in the subacute or chronic stages when we have reperfusion. And so what we'll see here is primarily an ischemic lesion, which then if you look on something like a graded echo, a T2 echo, or susceptibility imaging, you'll see areas of low signal centrally within the lesion. So they rarely look entirely hemorrhagic. It's usually a picture of ischemic infarct with areas of hemorrhage on the sequences which are susceptible to hemorrhage. This is a recognition of hemorrhage with ischemic brain disease is very important in human neuroimaging for the simple reason that if medical treatments, so thrombolytic drugs are used, the presence of hemorrhage would be contraindicated. Obviously, in our case, we're not usually giving thrombolytic medication, therefore documentation of hemorrhage is of interest, but really doesn't impact on clinical decision making. So the other form of infarct which we'll see, the main group is the lacunar infarcts, and so this comes from the gross histology. So pathology, what the pathologists find is these small craters in the brain which are filled with fluid, hence the term lacunae. And so these, say, represent, or thought to represent, intrinsic small vessel disease. And these are really common. So you're going to see these really, really frequently. So again, the appearance of these, they tend to be smaller than the territorial infarcts. But again, they'll have that typical sharp margination. They're often very bizarre shapes. And again, they'll usually have minimal mass effect, predominantly involving grey matter if grey and white matter are involved. The distribution will really depend on which of the perforating arteries is being affected. So the striate arteries will more rostrally involving the caudate nucleus and the internal capsule. The other perforating arteries will be involving the caudal thalamus and mesencephalon. You will sometimes see striate artery infarcts confined to the internal capsule, and this really is the kind of exception to the rule that this is a grey matter only disease. In man, there's a correlation between the clinical findings and the location of lacunar infarcts, and there are 5 lacunar syndromes described in people. So it's possible to predict from the clinical picture where the infarcts are likely to be. One of my colleagues at Liverpool, Rita McCalvey, did a very nice study correlating the distribution of lacunar infarcts and the clinical findings. And she's described 3 lacunar syndromes. So we have the paramedian ones up here, dorsal extensive infarct, and then the ventrolateral ones. So there's subtle differences in terms of the clinical presentation. One thing to note though is that both with paramedian and dorsal extensive lacunar infarcts, vestibular signs are quite common. So it's not uncommon for these animals to present with head tilt or central vestibular signs. So when we're imaging patients where we have expecting vestibular disease, it's important that we assess the thalamic region in addition to the brainstem, cerebellum, and the peripheral vestibular system. Again, just a nice example here in these images from the paper showing the sharp margination and this very shape to these lesions. Okay. So we also see not infrequently small cortical infarcts, and these are thought to be a different etiology from lacunar infarcts. So commonly we may see these very subtle lesions, and even though they're very small, they can cause quite obvious clinical signs. This is probably about as subtle a lesion as you're going to get, and you can appreciate that with some of these very small cortical lesions, if you have a low field MRI, for example, these may not be visible. Okay, these are probably a different etiology. These probably represent small embolic disease rather than intrinsic small vessel disease. Another example here of small cortical infarcts. So this is a dog which also had a large cerebellar infarct and had multiple infarcts in the cortex and in the thalamic region. So this is just a nice example of how subtle some of these cortical infarcts can be. But just note again, it's entirely confined to grey matter, sharply marginated, very homogeneous. The thalamic infarct, I find some of these small lacunar infarcts are often best seen in the dorsal plane image. So sometimes they're quite difficult to see in the transverse plane images. So, but again, they're quite easily overlooked. This is one situation whereby the flare sequence can be very helpful. So a lot of these caudate nucleus lesions are very close to the lateral ventricles. And as we can see in this case, it's quite difficult to appreciate this infarct next to the CSF within the lateral ventricles. Whereas on the flare sequence, where we've suppressed the signal from the CSF, the lesion's very obvious. So multiple infarction is not uncommon. This is thought most likely to be due to embolic disease, and obviously if it's embolic, it can involve more than one vascular territory. So these are the cases which we're probably going to struggle with, or you may struggle to differentiate from inflammatory disease, which is also often multifocal. But again, the thing to note here, although these are multifocal lesions, still hold true to that pattern of being predominantly grey matter and relatively sharply marginated. So multiple infarction, again, something which we see not infrequently. This is another example here where we can see in this case, the dog had a very large territorial infarct in its right cerebrum and multifocal small cortical infarcts. So this is the sort of lesion which you could potentially mistake for some form of interaxial mass. And likewise, these small lesions you could potentially mistake for inflammatory disease. Again, in this case, the history was very helpful. This was peracute onset of signs. This dog also had systemic thromboembolic disease. So this dog had massively elevated D-dimers and clinically had evidence of infarction in multiple organs. So we were fairly confident this was infarction based on the clinical picture and lab results. But again, this is a very nice example because it shows how subtle some of these small cortical infarcts can be. So we can see this lesion here, again, much better in the flare, and also this lesion down here. Eventually, we can see this small cortical infarct, again, entirely confined to grey matter. But as you can see, there's a lot of partial volume averaging artifact, and therefore, if we didn't have the flare, it'd be quite easy to either misinterpret this or overlook these small infarcts. So in these cases, the flare can be very helpful. In this case, we have diffusion imaging, and this shows restricted diffusion in the brain, which again adds some diagnostic confidence that we're dealing with ischemic brain disease here. So on the face of it, it would seem that diagnosis of ischemic brain disease should be straightforward. However, the literature suggests that actually this can be quite a challenging disease to diagnose. So this is the results from a paper quite a while ago now in JVIM, and what they found was that for the diagnosis of stroke, actually the sensitivity of MRI was relatively poor, but also the inter-observer variability was actually quite low. What does this mean? It means that for some infarcts, in a way, there is overlap in imaging features between infarct and inflammatory disease and neoplastic disease. So not every case will be that easy to diagnose. Another study by Vicente Severa and Wilfred Mai in 2011 showed that there was, for some observers, quite a high misdiagnosis rate between stroke and brain tumors, gliomas. And so I think we can, think, well, how's that possible? How can we mistake an infarct for a brain tumor? So if we look here, we have 3 different transverse T2 MRIs of dogs' brains. And you can see actually on the face of it, there's a lot of similarity between these lesions. So they're all relatively sharply marginated. So this one here is sharply marginated. They have a variable mass effect. This lesion here has got quite a large mass effect. These less so. These perhaps more poorly marginated. So if you think one of these dogs has got an infarct and two of these have a brain tumour, if you have a quick look at them and think, well, okay, which one would you diagnose the infarct on? So this was the infarct. So this is a really large territorial infarct. This was a piriform lobe glioma, and this is a more infiltrated glioma in a boxer. So you can see here that there is some overlap in imaging features. Again, in this case, the history was very helpful. I mean, this is an older boxer with progressive signs. And again, this was a kind of period onset. But again, you can see some of these features there is some overlap between the different disease categories. Another case here, so this is a superficial cortical glioma. Again, sharply marginated, this particular lesion seems to be involving just grey matter. This dog had a lot of seizures actually, so this dog's got concurrent postictal changes as well. So in this case, you could be forgiven for thinking, considering, could this be an infarct, because it certainly looks very homogeneous and sharply marginated. In this particular case, we have follow-up MRI, and that can be very helpful in some of the equivocal cases. And we can see in this case, a couple of months later, that this lesion has grown. So confirming that this is actually a glioma or a tumour rather than a vascular disease. Again, in this case, we didn't really think this was an infarct because of the clinical pictures and results of diffusion-weighted imaging and other features about the case. So this leads on to how can we increase our accuracy, or how can we increase our diagnostic performance when it comes to diagnosing ischemic disease. So this role of diffusion and potentially perfusion-weighted imaging come in. So if we look at the results from Wilfred Myatt and Vicente Severa's study, what they found was that there was about, depending on the observer, we had an error rate of about 10 to almost 50% where strokes were misidentified as gliomas, and conversely we had up to 10% of gliomas were misdiagnosed as stroke. When they had diffusion-weighted imaging available, what they found was there was an increase in accuracy, so they had no gliomas misdiagnosed as stroke, and an improved accuracy when it came to differentiating infarct from gliomas. So diffusion-weighted imaging is, in a lot of centres, would be kind of part of the protocol, and it's something which you need to be familiar with. You remember from kind of high school that water molecules have Brownian motion, so they have this random motion which is dependent upon time and temperature, etc. So obviously the higher the temperature and the longer the time, the more the water molecules can move or can randomly diffuse. Within brain tissues and within structures, we don't have this kind of random motion. Water is not freely diffusible, so it's constrained by things like cell membranes, organelles, and myelin, and so the mechanisms of diffusion within the brain are quite complex. So we have both intracellular diffusion and extracellular diffusion, and we also have exchange between different compartments. We have the effect of organelles and the alignment of white matter and myelin, etc. And so this leads to quite a complex picture of diffusion within normal brain tissue. So we can image how the water diffuses in the brain by diffusion-weighted imaging, and it's relatively kind of a straightforward concept. So on a diffusion-weighted imaging pulse, we have balanced bipolar gradients, which are 180 degrees apart, and they're just inserted into the normal MRI pulse sequence. So essentially what happens is that water molecules which move don't see both of the diffusion sensitizing pulses, and therefore they don't return a signal. So with water which moves, we see signal loss. However, if we have restricted diffusion, such as happens with cytotoxic edema, then what happens is that the water molecules see both of the pulses and they return a signal. So restricted diffusion on a diffusion-weighted imaging would indicate or may indicate a restricted diffusion. So with ischemic brain disease, what happens is as we have a reduction in blood flow, we have failure of the sodium ATPase pump, and we have accumulation of water intracellularly. We also have swelling of the cells and a reduction in diffusion of water in the extracellular component. So for both of these mechanisms, we'll have restricted diffusion with acute infarction. So the diffusion-weighted gradients or sequences run in 3 planes, and that's because we have a lot of anisotropy of diffusion due to white matter tracts, etc. So the diffusion-weighted image is acquired in 3 directions, and these are summed to give us the so-called trace diffusion-weighted imaging. So this should look kind of a fairly homogeneous image. So the degree of diffusion weighting is variable, so we can alter that, and it's depending how long we have the diffusion weighting pulse for and the strength of the gradient. So we can have different degrees of sensitivity to diffusion. This is known as the B value, and so typically we'll run a diffusion weighted imaging with 2 B values, and that allows us to actually quantify the degree of diffusion, and this is calculated and known as the apparent diffusion coefficient. So this is quite important because the diffusion weighted image also has T2 effects, and we don't necessarily know that a bright signal on the diffusion weighted image represents restricted diffusion or represents a T2 effect, the so-called T2 shine through. So it's always important that when we have a diffusion weighted imaging, we look at the ADC map. So restricted diffusion is bright on the diffusion weighted image and low signal on the ADC map. So why do we like it for ischemic brain disease? Well, for a couple of reasons. We can have alterations in diffusion-weighted imaging very rapidly in the face of ischemia. So in the human world, it's really important that we start treatment for stroke very early. And so this would be part of the stroke protocol because it allows very early diagnosis of infarction. And so diffusion-weighted signal changes will precede changes that are seen on the T2 or the flare sequences. This is an example here. So whereby on the diffusion-weighted imaging, we can see this small infarcts, which are barely visible on the flare sequence. Okay. Another example here. So this was a greyhound with a large territorial infarct in the territory of its middle cerebral artery. Again, you can see a typical appearance of an ischemic infarct. So this dog was imaged within 6 hours of onset of signs. And it's quite interesting because you can see that on the diffusion-weighted imaging, we have this much more extensive area-restricted diffusion. So this would suggest that the infarct or the area of ischemia is much larger than is suggested by the T2 weighted image. We had the opportunity to repeat the MRI a week later, and so the top row of images was the initial study. So again, we can see this very nice typical appearance of an acute territorial ischemic infarct with this grey map, predilation, quite sharply marginated. And then a week later, actually what we can see is that there's much more extensive infarction extending all the way back into the occipital lobes. And then during this time frame, the dog's also undergone hemorrhagic transformation. So this is just a really nice example of showing that the diffusion-weighted imaging can show the extent of the ischemic pathology much better than we can see off the standard kind of T2 weighted images in some cases, by no means not all cases. Perhaps a more useful use of diffusion weighted imaging in our situation is for aging infarcts. So we see restricted diffusion in the acute stages or peracute stages of ischemia. But then after about a week, it's somewhat variable. After about 5 to 14 days, we have this so-called pseudonormalization where ADC values return to normal. And then in the chronic cases, when we have necrosis and cavitation within the lesion, we actually have reduction in diffusion and increased signal on the ADC map. Okay, so the pattern of signal changes on the diffusion-weighted imaging can actually be very helpful when it comes to aging of infarcts. And so this is a nice example here. So this is an example of an acute thalamic infarct. So we can see this lesion here in the left thalamus with restricted diffusion. And then 7 weeks later, we can actually see it's undergone necrosis. We have volume loss. And actually we have, on the diffusion-weighted imaging, we actually have a low signal. So this facilitated diffusion. Another case here, but this dog has a small infarct in its cerebellum and a small infarct in its caudate nucleus. Quite hard to tell off the standard imaging, which is acute, which is the cause of the clinical signs. Whereas on the diffusion-weighted imaging, we can see this very nicely, this restricted diffusion with low ADC, indicating acute infarct, and in the thalamic infarct, the caudate nucleus infarct, we actually see high signal on ADC, again consistent with chronicity. So in this particular case, this is very helpful when it comes to actually aging the infarct. So interpretation of diffusion-weighted imaging can be complex. It's not specific for infarction, so there are other causes. So this is from the paper by James Sutherland Smith. So we can see that we can also have restricted diffusion with inflammatory disease and also with some neoplasia. So, very densely cellular tissues are very proteinaceous, such as an abscess, also show restricted diffusion. So it's quite important evaluating imaging, and I think the imaging feature in the imaging. Also, you need to have an understanding of the chronicity. So if you're assessing a suspect infarct, it's really important that you kind of consider the time frame, because that's really going to affect what signal changes we expect on the diffusion-weighted imaging. So just to finish off with some differentials for stroke. So we've obviously looked at how neoplasia can resemble infarction in some cases. It's important to recognize, obviously, that what we're seeing with our ischemic brain disease is essentially cytotoxic edema, and therefore other pathologies which cause cytotoxic edema we would expect to look similar. And so there are a few other diseases which are kind of the primary differentials for our ischemic brain disease. Total global ischemia, I guess you could perhaps consider in the same kind of group of it as the ischemic brain diseases, but rather than due to thromboembolic disease or intrinsic small vessel disease, this occurs when we have usually cardiac arrest or some form of anesthetic catastrophe. So in these cases, we will see a similar pattern of cytotoxic edema, which will look diffusion with imaging. However, changes may be more extensive. They're not typically confined to vascular territory. In pretty much every case, there is a known history of or cardiac arrest. So this is a disease which is kind of usually, you don't come across this as a kind of unexpected finding. In these cases, you normally know from the history that something's happened. Other kind of common causes of cytotoxic edema, postictal edema is something which you will see a lot of. And so postictal edema, again, causes cytotoxic edema, and predilection in the frontal, olfactory, temporal, and piriform lobes. Again, it's predominantly grey matter, so a lot of resemblance to the distribution with ischemic brain disease. However, these are associated with seizures and often with cluster seizures or status epilepticus. So again, the history is important here. Again, also the distribution differs. So it's quite common for postictal edema to have bilaterally symmetrical disease, which again is not something we expect with acquired ischemic brain disease. Again, these can often be very extensive, and again, they're not confined to vascular territory. So although they have a similar appearance to ischemic brain disease in terms of the grey matter distribution, the distribution again is different in the history. Again, in these cases, the clinical history is often very different as well. Again, we can see similar changes with the metabolic diseases. Typically, again, you're not really going to mistake this for infarction. So whilst some of these are grey matter diseases, these are typically younger animals with bilateral symmetrical disease. And so although they may be confined to grey matter, the distribution, again, is different. We don't have this association with the vascular territories. So perhaps the disease which you're going to kind of struggle with most to differentiate from some of the vascular lesions, so particularly the thalamic infarct or the lacunar infarcts, is inflammatory CNS disease. So multifocal distribution is obviously very common with inflammatory disease, but as we've seen, it's actually not that uncommon to see multifocal infarction as well. So which other features can be helpful? Well, certainly the shape and the margination. So this would be a fairly typical appearance of inflammatory disease. So we can see, relatively ill-defined margination to the lesions, in contrast to those very sharply marginated lesions we see with infarction. But typically, most inflammatory disease you see is a white matter disease. So really it's kind of the inverse from what we do with ischemic brain disease, in that these are predominantly within white matter, rather than the grey matter. So if we look at this is the paper a few years back now, which looked at the imaging characteristics to differentiate infarct from neoplasia from vascular disease. And what they found was that obviously lesions which we expect to see commonly with infarction, such as clearly defined margination, are actually quite in common with inflammatory disease. So this this shape and the distribution of grey matter versus white matter are quite important here when it comes to differentiating inflammatory disease from vascular disease.
Fraser?
Yes, sorry.
There's a question. Do you consider the ADC value low when it is less intensive compared to the DWI image, or when compared to the ADC value of a normal brain? So it'd be low when it's lower than normal parenchyma. Yeah. If that does that answer the question? Yes, the person says thank you very much. Okay. So just to kind of summarize of our kind of tour of infarcts of the brain, I think probably most infarcts we see are relatively straightforward to diagnose. They have this fairly characteristic appearance of this grey matter distribution. Sharp margination is important. I think history in these cases is very helpful. Most infarcts that we see which are clinically significant do typically have a peracute onset of signs, but then either getting better with no treatment or remain static. And so that's clearly very different from the clinical picture we see with inflammatory disease or brain tumours. Obviously, we can see acute onset of clinical signs with inflammatory disease and CNS tumours, but again, often going forward after an acute onset, the clinical picture is often very different there. In terms of diffusion-weighted imaging, it's certainly helpful, I think, and will certainly add confidence, I think, in some cases to differentiate inflammatory disease from other disease, vascular disease from other disease types. I think it is quite important, though, that you have an understanding of the complexities of it. It's not simply a case that an infarct has restricted diffusion, and therefore that's the key feature, because as we've seen, there's quite a lot of variation in diffusion weighting over the time frame. So when we're using the diffusion, we also need to consider the appearance of the image on the standard imaging planes, and also think about the temporal duration of the lesion. So it is useful, but is somewhat complex. So thank you for listening. Hopefully my dodgy internet allowed you to see the slides and the images without too much distortion, and would be certainly very happy to take any questions, or if anybody got any observations or comments. Thank you so much, Fraser. There is one question here. When reviewing DWI and ADC map imaging, what value has the B0 image, and what does it add?
So the B0 image has no value. So the B0 image is essentially a T2 weighted image, but it's a low resolution image. The reason why the B0 value is generated, because it allows you to generate the ADC map. So if you don't have a B0, you can't generate an ADC map. So that's essentially why it's there. So you don't look at it. I mean, it's there because it allows you to calculate the ADC. If you didn't, you can acquire a diffusion with only one B value, but then you can't generate the ADC map.
Thank you so much was the comment. There have been really sweet comments in the chat right now that they absolutely loved your lectures and this was fantastic and they learned a lot. And also from my side, it was great. Thank you so much, Fraser. We could hear you. Well, there were a few little interruptions, but it was still all fine. And we could see your images, your beautiful images and beautiful cases fantastically. So if there are any other questions, please feel free to write them in a chat. Wow, the chat is going crazy with thank yous at the moment. Otherwise, I'm just gonna let you know that we are very thrilled that you could all make it to the summit talk, and we love to have you here. Our next summit talk will be next week, May 13th, with Dr. Olga Travetti about pituitary MRI. And you should have received an email today about the summit talks. And so you can register for that session on that email by clicking on the box. Fraser, thank you so much for coming. Hang on, there's one other question here in between. The infarct in the brainstem should be described as a territorial or a lacunar infarct?
So those are usually classified as lacunar infarcts. So the territorial infarcts are usually, we talk about those when it's an infarct in the territory of one of the major arteries, whereas the infarcts in the brainstem are occurring in the small end arteries, the small perforating arteries. So that would be a lacunar type.
Perfect, thank you. I hope that answered, yes, it did answer the question, great. And I'm sorry that I couldn't read your question before because, as I said, the chat was exploding. Thanks so much for coming, everyone. Unless there's any other question, I'm just going to wait a few more seconds, then we will finish the meeting. And I hope you all have a lovely rest of your day, a whole day, depending on which time zone you are in. And we hope to see you next week.
Great. Thank you, everyone, for your participation.
Thank you so much.